Dr. Yodi, you may begin.
Welcome everyone to the second session of the 2021 Southeast Asia Regional Meeting on Surviving and Thriving, Innovating Through the Pandemic and Beyond. My name is Yodi Mahendra Datta. I'm currently Vice Dean at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia. Now, we're currently still in the middle of a pandemic, and we all hope this will pass soon. But in any case, unfortunately, this won't be the last pandemic we'll see. In fact, we now live in an era of pandemics and other existential threats, such as climate change. So it's really critical to learn how to be more resilient and how to recover better from global health crisis. So we need to take stock of the lessons coming out from the experiences in these countries across the world with the COVID pandemic to better prepare us for the next crisis. In today's panel session, we will hear lessons and reflection from distinguished AAHCI members in Canada, China, Indonesia, and Malaysia. Each panelist will present for about 7 to 10 minutes, after which we will have a facilitated Q&A session. You will be able to type your question in the chat box, and we will deliver your question to the panelists during the session. So to save time, let me start with introducing the first panelist. Our first panelist, she's the farthest from Asia at the moment. She's based in Canada, Professor Andrea Lam. Professor Lam has been a clinical academic physician leader for 2 decades, beginning her radiologist career at the University of Ottawa and was recruited to Western University in 2000. She was appointed Vice Dean, Clinical Faculty Affairs on January 1st, 2020 for a 5-year term at Schulich School of Medicine and Dentistry, Western University, a role which is enabling her to lead and develop faculty experience, including faculty well-being and professional affairs. Professor Lam, welcome to the panel, and the floor is yours.
Thank you very much. I'm just doing a sound check and a video check, and I'm thrilled to be presenting tonight. I come to you from London, Ontario. I have no conflicts of interest, although I do receive a stipend for my position as Vice Dean, Clinical Faculty Affairs at Schulich Medicine and Dentistry. So for this evening, some of the learning objectives will be for the participants to be able to take a look at our program, describe our development and implementation of a peer support program, and also learn about our program and if a similar program is of value for yourselves. In any pandemic, and we had SARS in the past, and now we have COVID, it was really important for physicians who are in the front line to be able to both help our patients as well as help ourselves. And what we came up back in March 2020, when COVID came to Canada, that our own faculty well-being really matters to us. And the only people that are going to care for ourselves is by building a program for our peers. So during that time, I'll tell you a story. I was away on vacation in Aruba. And when I came back from my vacation, all the airports were starting to close. I was a newly minted Vice Dean. I just started in January. And so there was really no program. And we needed to start from the beginning. Let me tell you a little bit about our journey. Intuitively, our organization had already started with engagement on physician burnout. And this is pre-pandemic. We had done a needs assessment, and we found that in January of 2020, 24% of the respondents indicated that they had a high level of burnout, not unlike burnout levels in other countries and published burnout. 30% of those physicians felt they were quite anxious at work. And this is pre-COVID. So we started off with a baseline. At the beginning of COVID in April, there was another survey, and that came out with strategies to enhance resilience at work. And what we found was that 75% of staff and physicians felt that speaking with a colleague was the most helpful strategy. So that sets the stage. When we're looking at developing any program, I like to think of leading change management by first having the vision, which we just spoke about, knowing what the incentives are, having the skills, moving on to having resources, as well as then coming up with an action plan. Our health and well-being are very much linked to quality and safe patient care. And as physicians and healthcare workers, that is paramount to what we do. So what is our incentive? As many of you know, back in the days when we could travel, and in Canada, we have Air Canada, our airline pilots really had a system of fellowship of pilot assistants that they developed for many years. This is vested in also knowing that peers can help peers because we have the same experience. Our Canadian Patient Safety Institute also developed many resources, online tools for how to implement a peer support program. We all know that there is a lot of literature and publications both throughout the world. In the United States, there are JAMA publications by Shanafelt, who is well known. In Canada, we have our own Journal of Canadian Society of Physician Leaders, and there is much evidence in the literature to support the need for developing a wellness program. So some of the skills that are required once you want to implement a program to support ourselves is to how to start. Well, we started in the usual manner. We developed a steering committee and a well-being program, and we called it Peers for Peers. It was also important for us to establish immediately a generic email that allowed people to contact us. We utilized the decanal team of leadership to help start the program at the beginning. We have now morphed into a more executive committee to sustain the program. So we have an academic system where 14 clinical academic departments exist in London. We have two sites, a primary site in London and a primary site in Windsor. And in between these two primary sites, we have an entire distributed network of physicians across Southwestern Ontario. In total, there are about 2,500 clinical academic faculty, both in full-time and part-time practice. So when we started thinking about a program, what exactly are we going to do for ourselves? It was important to recruit peers, other physicians, so that they have that understanding. On the flip side, it was also very important that these peer supporters were not evaluators, did not hold a specific academic or title position in order to provide the psychological safety that is so needed when they reach out to their peers confidentially. The program is based on training our peer supporters, because as you know, as physicians, we are all trained in multiple different specialties. And without training, there is no way that they'd be able to provide that support. When COVID was in full bloom, we had no choice but to train over Zoom, as we are having this conference over Zoom today. What is our Peer for Peers program? It is a program that's vested in empathetic listening, providing support without judgment, and referring the individual to resources if there is a requirement. What we did find is that most of these encounters only required actually a first or a second encounter, because truly sharing with someone who has the same experience is very helpful. It is ideally a selected peer who is passionate about this work, and we called our peer supporters well-being leads. What is it not? It is not there to provide therapy or to give specific advice. We do not instruct on what to do, and we don't diagnose. Let's just pause on that. As physicians, what we do is make diagnosis. We provide care. This is a little bit counterintuitive. And we are not here to fix challenges faced as a result of the pandemic. We, as a single individual peer, cannot fix that, and nor can we sometimes fix systemic difficulties. But we can truly provide emotional support. What's really important in the program is to have the back end support. I alluded a little bit to the training, and I'm going to focus on that. It was also important for us to have communication resources. We just leveraged technology and had Microsoft Teams, and we utilized our website. What we do have now, and this is the beginning of our journey, we leveraged our expertise on site to come up with a curriculum. And in Canada, we have our Royal College, and the MOC stands for Maintenance of Competency, and continuing professional development. And we accredited our program. So we provided 7 sessions over Zoom to all of our well-being leads. On the back end, though, we had incredible resources at our university, psychologists, as well as our clinical peers, psychiatrists within our academic health science center. So as you know, there are some basic steps of empathetic conversation that start with invitation, opening, listening, reflecting, reframing, and of course, ourselves, we need to breathe. Then make sense of what we're hearing, coping, and then closing the session. Some of these sessions are almost chance encounters. They may be a scripted meeting, or they may be as simple as stopping by at the coffee shop and having those conversations. If our physician needs help beyond 2 encounters, we then refer them on. It is important as well within any program to support your supporters. It's almost intuitive. So how did we do that? We continued to provide ongoing training. We had monthly rounds for our peer supporters where we would listen to their challenges and their successes. And as well, we continue to expand our program through development, education, and networking sessions like we are doing today. We developed an action plan. The first 4 were developed very quickly. We simultaneously trained, developed, and launched almost all at the same time. And within a month, we had our plan go from framework to implementation. So at Schulich, I coined the acronym GPS, and you all know GPS. We know how to get there, but it stands for Guiding Peers at Schulich at our institution. As I alluded to, once we had a needs assessment, we trained our team and we leveraged our resources. The way it works is if faculty needs help, they contact us. Our well-being leads provide the ground level support. They're all posted on their website. And then if they need additional support, it comes to the decanal team. We started with 17 well-being leads. We now have expanded and we have more than 30 divisional leads with a total of more than 50 well-being leads throughout Schulich. We have now obtained a new interactive platform called Moodle, and in September of 2021, we launched our continuing professional development program, which is asynchronous, meaning it can be accessed at any time. It can be utilized for other programs or other institutions who may wish to develop a well-being program for themselves. What we also did, just to share with you, did it work? So we have a program. During the first wave, we had 151 encounters, and the second wave, it decreased slightly to 85. To date, we have over 300 encounters by wave 3. The most typical encounter is an informal chat. It's in the moment. Why were the encounters requested? Mainly for mental well-being. That consisted of around 50 to 60%. Family concerns, and of course, during the first wave, PPE was a huge concern. Less than 5% of the referrals make it to the decanal office. And in terms of gender distribution, women access the program more than men, 2/3 to 1/3. So as I alluded to, we now have an executive committee. We provide support for the many physicians and clinical peers. And now we're able to offer training curriculum as part of our own faculty development and through our CPD CME office. So thank you very much for inviting me to speak today. I hope I've given you a snapshot of what we do, and I'm happy to answer any questions.
Thank you very much, Professor Lam, for reminding us on the importance of maintaining our well-being throughout this pandemic as part of resilience, and also sharing that very innovative program, which is a really innovative practice which we can all learn from. Okay, before we move on, so I'm going to introduce the second panelist. So we are moving from Canada all the way to Malaysia. And we're going to learn from Professor Sanjay Rampal. He is a professor of epidemiology and a deputy dean of research at the Faculty of Medicine, University Malaya. Professor Rampal was medically trained in India and served in the Ministry of Health Malaysia before joining academia. He's a fellow of the Academy of Medicine Malaysia and chairs the Specialty Education Subcommittee for Public Health Malaysian Medical Council. Professor Sanjay Rampal, welcome to the panel, and the floor is yours.
Thank you, Yodi. I will now share my slides. Do you see my slides?
Yes.
Thank you. So basically, I will talk about the Malaysian experience and response towards this COVID-19 pandemic under this panel. My name is Sanjay Rampal. I am a professor of epidemiology, and I'm also deputy dean for research in the Faculty of Medicine, University of Malaya, Malaysia. So first of all, just to spend a minute or two on the epidemiology of COVID-19, being an epidemiologist. So one thing which is very interesting is if you look into the region of ASEAN, and you look at the many countries in ASEAN, what you would appreciate is that COVID-19 has hit each of our country at different points of time. So that basically what you have had is you have had propagations of outbreaks in the various countries at different points of times, and typically not as one outbreak, but multiple waves. And another thing that you notice is that the burden of infection is also different in the different countries. Now, this is just overall totals of cases reported. Now, if you look at this figure, which actually adjusts the total reported cases for the population, what you will notice is that you can see the many countries here, but I will just focus on Malaysia. In Malaysia, we thought we had a wave actually in March to April of last year. But as you can see, that was actually nothing much. And then we had subsequent waves. Each wave that we faced, we thought that was the big wave. But ultimately, the wave that we had in the recent past few months, when we were reporting 20 over 1,000 cases a day in Malaysia, and many of these cases were actually localized in the central region of Malaysia, we actually had a very big spike in COVID burden, and which actually strained the healthcare system tremendously. So now moving on to University of Malaya as an academic health center. Now, if you look at our purpose in living in with a world with COVID, right, we still push on with our functions of provision of medical education, provision of clinical service, preventing intra-hospital transmission of COVID-19. And then we contribute to the nation's testing and lab services. All our academics continue to do research in COVID, whether be it in fundamental research or in translational research. And in addition to that, we have seen a new need for the field of public health, and has been stated by our keynote speaker that it has become a more important component. The perception that public health is now a more important component of any academic health center. In addition to that, we have seen the need to also move out to our community. So just to summarize, just to list down a few activities of the first part of provision of medical and healthcare, that in Malaysia, UMMC, which is the University Malaya Medical Center, which provides clinical care for our AAHCI, we established a task force to manage COVID-19 very early on in 20th January 2020. I think this was very important because it created clear governance guidelines, and most importantly is that this committee was inclusive. That means it included the different members of the AAHCI onto a common ground. And with that, it was also very multidisciplinary in nature, including the various expertise that we had across the different centers within the AAHCI structure. Now, there are many functions to it, but one of the major functions of this task force was for continuity in clinical care, right? Continuity in clinical care, which then moved on to the public health approach towards prevention and control in the local community. And the UM actually came up with one of the first guidelines for a comprehensive system of prevention of intra-hospital transmission of COVID-19. It actually started off with piecemeal efforts at infection control measures in the hospital, risk assessment, surveillance, contact tracing, but ultimately it moved on towards a system whereby what we do is we employ a preparedness and response system within the AAHCI structure for the community of the AAHCI. And now when I define the community of AAHCI, is defined as the staff and students within the AAHCI and the patients. So these are the main activities of the preparedness and response: case notification, contact tracing, risk assessment, testing, surveillance, and outbreak management. Now, in addition to that, out of need, I guess, there was this group of researchers from the Faculty of Medicine and the Faculty of Computer Science and Information Technology who worked together in coming up with a remote monitoring system for COVID-19 patients. And basically, this comprises of two parts. One is a Telegram chatbot, which actually interacts with the patients or with those who are under quarantine. And the next part is the medical dashboard, which is actually helps our medical practitioners, our primary care practitioners, to monitor the status of those patients who are under the system. Now, in addition to clinical care, we also ensured continuity of medical and health sciences. And I think there were different paradigms, right? So if you look on the left, face-to-face was what it was originally is. But when we first faced COVID, we actually had to go into a mode where we suspended education for a little while to figure out what was the safest way to proceed. And because there are different schools, different faculties within the AAHCI. So some dealt with direct patient care, some dealt with subjects where you don't have direct patient care and you can move on much more faster. So basically, we suspended our learning activities initially due to safety, and also at times when our healthcare system gets strained. And then we quickly moved on to a virtual system. So with virtual system for programs like public health, we could roll out the virtual system much more faster. But with medical education, with the undergraduate students, it took a bit more time to figure out how to deliver learning through virtual means. And now two important factors that cropped up was, one was infrastructure, that you needed a proper IT infrastructure to deliver learning through virtually. And the second thing is with access. So access as in students' access to the information that is being provided synchronously or asynchronously. And there are times when we had virtual learning, when our students go back to their hometowns, and their hometowns do not have sufficient access, just due sufficient access to bandwidth, just due to the prevailing infrastructures in those areas. And ultimately, after I would say a couple of months, we have moved on to a hybrid system, and our hybrid system has been in place for a year. And now we're looking to move on to a face-to-face system. Few issues that crop up in a hybrid system, especially in hybrid system, is again compliance to public health and social measures, the infrastructure, the access, and now we're moving on to some of our programs where it's being delivered purely face-to-face again, trying to move on into this next phase of the pandemic and living with the pandemic. And again, we are looking at compliance of issues. We will look at compliance of our students, our academics, to public health and social measures. And another important point is, as we rationalize COVID-19, I think it's very important to rationalize the cases. So in Malaysia, we are lucky, as in we have vaccinated a very, very large majority proportion of the adults. And so that we should rationalize the numbers. And I think that's taking some time, as in to think about the numbers in a much more rationalized way. Now, in addition to that, coming to research, I didn't want to mention too much research activities, but one important point that I think we have done is translation of the research, a translation of the evidence base for the communities. So a big problem has been misinformation and disinformation. So what we have tried to do over this past year or so and moving forward is that, number one, the Faculty of Medicine has become a university COVID-19 trust node. So for information, so whereby we provide guidelines, we provide flowcharts, information about COVID-19 management, prevention, and control. In addition to that, public health department within the Faculty of Medicine has established itself as a Malaysian COVID-19 trust node. And this was through various means of translation and through the media. In addition to that, we also established a COVID-19 epidemiology dashboard for Malaysia, which gives the information for the previous 3 months to help influence policy decisions. Now, in summary, we are moving on to a world with COVID-19, and we have to live with it in a sustainable manner, right? I think it's important to note that our academic health centers are nested within the local communities, nested within the local governments, nested within the federal governments, and we belong to a global village. So as moving forward, I think important factors are to transform how we learn, improve our digital infrastructure to make sure we have an agile health service, improve preparedness and response, to make sure that we have sufficient testing and lab services. And as we move on, we empower our local community first, then going to the local government, at the state level, at the national level, and at a higher regional level. And lastly, we try to influence policies, because I think AAHCs have the expertise and are very important to influence expertise. With that, I thank you.
Thank you very much, Professor Sanjay Rampal, for sharing with us that very comprehensive response from University of Malaya to the COVID-19 pandemic. Okay, we will now move on to the third presentation. So we move from Malaysia to Indonesia, where we will hear from Professor Dr. Ahmad Ramdhani. He's an otorhinolaryngologist, head and neck surgeon in the Faculty of Medicine, Universitas Airlangga, and Dr. Sutomo Academic Medical Center in Surabaya, Indonesia. He's also Vice Dean for Academic Students and Alumni Affairs, and also as First Secretary in Academic Health System, Universitas Airlangga. Professor Ramdhani, the floor is yours.
Thank you, Professor Yodi. Thank you, everybody, for let me talk about our progress in during COVID, about the learning in Universitas Airlangga, especially in Faculty of Medicine. And right now, I want to share about the hybrid methods as an effective teaching and learning strategy during COVID pandemic. As we know, almost 1 year or more, we have online situation. We give the lecture by online and also give the task by online, and also everything about student with online. And we until now, and we see that some of the advantages and also disadvantages with the online method. And right now, we know that the learning from home is an effort to reduce project activities that we recommended by the COVID. So we cannot meet each other. It is very limited to us to communicate with others. And learning from home, some have negative impact on students, such as threat of dropping out. Some students are forced to work to help family finance in pandemic crisis, and also student growth and development constraints, and learning achievement gaps, non-optimal growth, risks of loss, and cognitive learning and character development. And also, there is psychosocial pressure and domestic violence. Some students rarely meet lecturers, and never meet friends and outside from home. And we have the principal policy in education right now during COVID is the health and safety is the first. And then this healthy and safety for students, for educators, for lecturers, for staffs, and for families, and etc. In environmental of the student and also in faculty. And then the growth and development of students and psychosocial conditions. And for now, the license of offline learning, we have a permission from the city government through COVID-19 task force, and also the chairman of the task force in the university. And then we should have permission also from dean and of the faculty or school, and also the study coordinator program in the faculty, and also from the family, from the parents of the students, they have to give permission also for the offline learning. And also the offline learning should notice about the level risk in the region. And we know that in Indonesia, for several months ago, it's very red and it is difficult to do the learning and also study between the lecturer and the students. And right now it is very happy because the number of the COVID patient is decreased. And I think we try to start the hybrid learning since maybe 2 or 3 months ago. And this also, we need the readiness of human resource, facilities, and infrastructure. And we know that the new normal should more prepare of infrastructure. And now we also coordination with the COVID-19 task force in the universities. And also the student, lecturers, education staff have been vaccinated completely, dose 1 and 2. And some of us have the third dose. If never been vaccinated, they can attach negative COVID-19 test result. The academic community are in good health, and those who have comorbidities history can manage and control. And students can choose on only learning online learning only. Some of our students have a morbidity, such as they have malnutrition, they're very fat, or they have the severe allergy. So we give the permission for them to do the online learning only. The overseas student must in a good health, self-quarantine for 14 days or obtain negative COVID-19 test result. And for students who show positive symptoms during screening, can report to COVID task force in university. And also the student who confirm positive and have no symptoms are required to self-isolate at home. The faculty, school, study program must apply health protocols in offline learning both before and after courses, practicum, or examination. For the health protocols in our institution, should avoid 3C, the closed spaces, crowded places, close contact situation. And we have to using mask, physical distancing, washing our hands, and avoiding crowds and reducing mobility. We make some annotation in the corner of our office in faculty and also in check the body temperature before the student or the lecturer entering the class. And then we avoiding use indoor area, occurrence of close contact. We also provide hand washing, hand sanitizer in strategic places in our institution. And for individual, we we suggest our student and also our staff was using 3 layers of mask of disposable medical mask as the health standard, and implement a minimum distance of 1.5 meters between people, and limiting use rooms of maximum of 50%. And then implement to care each other and protect, and also practice proper cough sneeze etiquette. For the health protocol, we provide a temporary isolation room for academics who have COVID-19 symptoms, and implementing a mechanism for handling COVID-19 case finding in environment universities. Provide support for emergency action handling COVID-19. Also, we do the task force that actively asking the staff and also the student, and we give the a G form who always every day to be reported to the task force. And we report COVID-19 task force university in a COVID-19 case is found. Application of hybrid learning. In hybrid learning methods, students can take part in offline or online learning activities. The implementation of offline learning still using health protocols in order to not create new cluster in campus. Learning activities using online lectures can take advantage of online interaction facilities with learning management system, such as Google Classroom, Zoom, Google Meet, Skype, etc. Hybrid learning is the most appropriate method to apply during pandemic for now. The benefit of hybrid learning: a flexible learning experience, asynchronous communication opportunities, the freedom of independent academic exploration, and more efficient use of resource. The hybrid learning from the Christensen Institute, we saw that they use a rotation model, flexible model, self-blended model, and then enriched virtual model. But in Universitas Erlangga, we use the blended or hybrid learning. We think what is the outcome of the lecture. If the outcome is only on cognitive domains, and we can full in online, but if the outcome they need like a skill or practice in learning, so we give the permission to do it in an offline situation. And the standard room used by blended learning and hybrid is a room with adequate area and good air circulation. The classroom for courses with a minimum distance 1.5 meters and maximum 50% of capacity. And the attention, the time gap between first course and the next course to avoid student crowd, or if possible, provide a transit room. And also we arrange a student flow in and out to avoid crowding. This is our class. Our class usually fill with until 200, 250 students. But for now in hybrid learning, we only give permission only 25 until 30 students. And depend on the class. If the class is smaller, we only give on 5 until 10 students. And for the skills lab, we let the student and also the instructor to do the specific skills in a small group. So they in 5 until 10 students in a group, and they change after the first topic, and then they make a circulation for at the day, and then they have a different experience in the skills lab. So like this. And for summary, the pandemic of COVID-19 affects all aspects of life, including education. The learning from home shows some disadvantages. Hybrid method is a learning solution. The healthy and safety aspect is the main consideration, and the coordination between stakeholders need to be done to prepare good learning. In case of psychomotor targets, offline learning is still an option with strict health protocol. Thank you very much.
Thank you, Professor Ramdhani, for sharing with us how you try to implement a hybrid teaching program and still keeping it within the safety protocols in Universitas Airlangga. Okay, now we will move to the last presenter. So we will move from Indonesia to China, where we will learn from Professor Jialin Zheng. He's a distinguished professor of neurology, neuroscience, and regenerative medicine at Tongji University School of Medicine. He serves as the Dean for TUSM and the Director of Brain and Spinal Cord Clinical Research Center of Tongji University. He served as the Associate Vice Chancellor for Academic Affairs and the Associate Dean for Graduate Studies at University of Nebraska Medical Center before he joined Tongji University School of Medicine. Professor Zheng, the floor is yours.
Thank you for your kind introductions, and I really enjoyed the three speakers' talk. And so my talks will be also similar. And what is our response, and in the past, and what we can do for the future. So clearly, the COVID-19 have provided the challenges and opportunities for us. And as a talk presented by previous speakers, and clearly they provide a huge impact on teaching and learning. And also, we would like to share some experience and what kind of international anti-pandemic cooperation or global public health governance can be done and during this crisis. And what could be the new strategy for international collaboration, some kind of a source to provide for discussion. And as you are aware, China actually start this is in the February of 2020s, and there was a preparation stage, and when the crisis happened, and so that faculty are really starting to think about the reading for the online teaching, ready for the online teaching process, and what kind of resources need to be provided for teaching online, and also what could be a teaching guidance and manuals for students and faculties during this process. And we all, through this process, even we had some experience for online teaching, but this is a very large scale and also cover everyone in that process. And try to, in March and April, try to, for the basic configuration for each classroom, and provide kind of a teaching assistant, and how to make sure the teaching quality can be managed, and provide the teaching coordinators for that process. And then during the April or July of 2020, and students can come back to the campus. So as just mentioned, there will be a hybrid of the online and offline things, and how to improve in online educations and online midterm and final exam, how this can be conducted, and teaching feedbacks are collected and assessed by the teaching quality supervisors. And then during the September, November age, and because of the time goes, and can see some psychological adaptations of teaching and the student for the online things, and also the students get back offline, offline in campus, and have more of an education. We also, Tongji University School of Medicine offer the MBBS class for international students. Most students are come from Asia, Americans, European countries, and they are teach by English. And also those MBBS course offered online. So after this kind of about several months of this process, and 2020 to now, and we can progress in developing a skilled online teaching workforce, and we can see some kind of a positive changes in student attitude towards online teaching, because it is ongoing, and the transformation of educators and about ideas, along with online ongoing kind of reforms of the medical education. They do provide a lot of challenges, but also open a lot of new windows for many things what we can do for that. So active adaptation in a time of a crisis, and clearly, and it is, we were not prepared when we start that, and a lot of course information, student information, how those things can be collected, provided, and for that, and even for reservation of online classroom, meeting rooms, and that's become also challenging issues among different discipline, different things, and assignment, and submitting a pre-class or post-class seminar assignment, and how to marking the assignment and online quiz for that process, and also the file transfer for that, and lesson plan, and curriculum, courseware, all those reference material, and how this can be provided, and online live stream virtual classes, and online recording, and broadcasting teaching, and also for teaching material, kind of online recording, and provided to different students. And we need to also divide different course group, teacher group, teaching assistant group, student group, and online teaching quality supervisors group. And for teachers group class, those groups need to be arranged, and how to organize managing, and how to make effective discussions, and for that process. And then clearly evaluations, and how to conduct in-class quiz. We're going to encourage students actively involved in a virtual class, and we need to analyze the student in-class performance and learning progress. And it could be very good how to compare the online performance as compared to offline. That can be very helpful for that, and also conduct online exam, and provide an online exercise. So those are the we gain a lot of experience, and also many things were not possible, even for the faculty and the student guidelines. And our committee meeting usually are conducted by in-person meetings for for the student defense, all those things. But we need to change all the rules. That rules would allow the online defense, or online committee meetings, or online different committee meetings are officially effective to be for the management process. Secondly, I'd like to provide a brief introduction for International Blended Program. That is a program we developed together with McGill University Department of Family Medicine. As you are aware, McGill University are top university in the globe for family medicine research and education. So starting August 2020, and we spent about a year actually develop and working on this program, and actually applied into our teaching for teachers. As also you're aware, family medicine program are not very strong in China. It was strong for certain times, and for the back of doctors, but then China moved into big hospital structures, and family medicine got weaker in the past almost some 30 to 40 years. And it's about 10, 15 years ago, China started pay attention again. What is how to change and make a better family medicine program because of the medical care are changed. So this is a blended education for teachers, leaders in family medicine or called general practice in Tongji University School of Medicine. We actually, during the past 10 years, Tongji University School of Medicine put a lot of effort for how to make a best model for training or for practice family medicine in that. So we actually accept the called community health science centers, because in China, they are kind of a 3 AAHCI hospital or territory hospital, like, central hospitals are in the part of the Shanghai. But China also in the past about 10 years built many called community health science centers. They are actually built very close to those different living areas, and they can provide a convenient clinical care to people around these areas. So those areas are usually provided for family medicine, general practice, or even pediatrics, or like vaccination, or those things. So Tongji University believe that it is important not just have affiliate hospitals, but also have affiliated community health science centers. Then those community health science centers, they will feel they are also important. They can become a university faculties. They also value the quality of the education, quality of clinical cares. They are equal to 3A hospital in China. So we started that in 2017 for that. So, because of that, until the 2021, we already accepted 7 clinical health science centers to be affiliated with Tongji University School of Medicine. So we actually, in this blended program, McGill University and Tongji University School of Medicine are getting involved teaching those people in those clinical health science centers and get them to be actively involved. They can help to teach the ideas, the concept of primary care in the community health science center to our student, to our resident, to our those new trainers. They are in different areas, but they will be transferred into family medicine in our areas. So for that, and with McGill University, we formed the joint education committee, like education leaders, key organizer from both sides, for the mutual on-site investigation, like a clinical teaching setting, and provide online surveys and focus on group discussions. And we collect the course preparations, like participant engagement and feedback, and agendas for different face-to-face meetings, and assignment of also discussion topics for those leaders to be involved in the blend program. So we do have using a different communication platform like Zooms, and also in China for different part of the world. And we are very often use WeChat, like Facebook in the US, and WeChat is very popular multimedia platform for communications. And so we're also involved in that. So we do have a real time through the Zoom for the face-to-face discussions, which will be facilitated by McGill and the Tongji University instructors. And also for the learning activity supporting resources, we will be using the modular for that, recorded lectures, and will be provided to the learners for that, engagement for questions, quiz, and also reading materials, reading assignment, like online test and everything. And for the instant concept, we provide kind of a WeChat group. They can have a teaching support, schedule arrangement concern related to content, questions, discussions, announcement, all those things. So we also made a kind of what are we going to face together for COVID-19 for that. Conduct family medicine physician during COVID-19 pandemic, encourage sharing for that, and language things is important because English, Chinese subtitles for that for the presentation, also presenting both Chinese and English for that. So those actually through this program become a kind of we have a first group actually through this and has been very successful get that. So this for that it's clearly lifting traffic and sharing high-level education resources, promoting a self-direction learning process, and also could have potential to reach great numbers of participants and benefit remote area at the relative low cost. The Tongji University and McGill University is planning to offer this joint program for more cohort in China for that. And lastly, we also like to provide, COVID-19 does provide great opportunities, and it is a great for us and the Tongji University decide to provide a new about 66.87 acres of area and a space floor space about 200,033 square meters of that new areas for Tongji University School of Medicine. This area actually is bigger than current Shanghai Jiaotong University School of Medicine or Fudan University School of Medicine, and clearly provide more opportunities for us to recruit talent faculties, recruit outstanding students, also into international student for that. And so this is a kind of a new development and provide opportunities more for Tongji University School of Medicine. So we are in the very active construction area, and we already moved to the campus already. Out of 3,000 students and the faculty already moved in, and we are moving the research faculty by the beginning of next year. So we welcome our colleagues from South Asia or the people in the area come to Shanghai and visit with us and discuss the future more collaboration in medical education, in research, and after that. So this is my presentation. I really thank you for your attention and also welcome any questions. Thank you.
Thank you, Professor Zhang, for sharing with us how Tongji responded comprehensively and adapt the system as the pandemic evolves, and also sharing the future, the new campus, which was very exciting. Okay, so we are now in the Q&A session. We have around 20 minutes for the Q&A session. Now, just to remind, as a reminder to the participants, you can type in the chat box or raise your hand and unmute yourself to ask your questions. And if you do that, we encourage you to turn on your video and participate in the discussions as well. So we already have some questions in the chat, as you can see. I will start with the first one. So the first one is from here, from Dr. Budi Iman. He's asking, do you have tools to predict the next waves of COVID-19? And how do you anticipate the worst case scenario? I think anyone could respond to that. Anybody wants to start about predicting the next wave and also anticipating the worst case scenario?
Thank you for the question. So I think there are two issues here. Number one is predicting the next wave, and number two, influencing policy to deal with the next wave. So I think up to now, many of the countries here, and I will talk about Malaysia. In Malaysia, we have kind of summarized or listed down the indicators that we are interested in, that we will be monitoring for the next wave. One important factor to consider here is whether a population is vaccinated or not, and I think that's a very, very important consideration. So I think in a post-vaccinated population, one would actually monitor the hospitalization rates, the usage of healthcare, and you would monitor down there, but at the same time, you would also monitor indicators such as public health service utilization. the ability to provide contact tracing, the ability to quarantine, and fast response and risk assessment of the cases. So what we have found from the past is public health services first get strained, get overwhelmed, and after there's a lag period of 1 to 2 months, and that's when you see your hospitals start building up. So the idea is, do we have the tools? I think we do have the tools of predicting, of monitoring. Prediction is a different issue because I think there's a lot of uncertainty with prediction, but we do have general predictions. Like in the next 3-4 months, we will have another wave, for example. But to pinpoint it, I think there's still a lot of unknown factors out there. With regards to influencing policy to manage that, I think that there are many other issues that come into play. Importantly, governance and the government of the day. Thank you.
Thank you, Professor Rampal. Does anyone else from the panel would like to add to that, to respond to that? Anybody? No? Okay. Professor Ramdhani, you're unmuting yourself. Do you want to add or?
I think in Surabaya, we also have experience in doctor organizing in Surabaya. So we have we can observe the behavioral of the people. If we see that the people they are obey with the government rule, so I think we can predict that the COVID number will be decreased. But if the people obey, they don't do the health protocol in a good way, I think we can see the COVID will be increased. Some of us can predict it in our environment. So because in our city is we have a different level of the education, so we have to understand the grassroots people. If the grassroots do the health protocol in a good way, I think it is a good prognostic for the future, Dr. Yoti. It is in my observation as a practitioner in grassroots like this. Thank you.
Thank you, Professor Ramdhani. Okay, on that note, I think we can move to the second questions, which is about how do you evaluate competencies in a blended hybrid method? Perhaps this would go to Professor Ramdhani first, and if others wants to add, please feel free.
Okay, thank you, Professor Budi, on the questions. I think this is still an obstacle in doing the examination ideally. When we do the examination, depending on the learning target, if the learning target only such as cognitive in the cognitive area, so we can do only the examination or the online examination. But we know that we do the modification. We have a modification and the examination, but it is very necessary the honesty in doing examination between the student and especially in students. So we don't want the student to doing cheating or do something about the examination. So it is not easy, but some of us suggest the student using two cameras. So the first camera is for from the computer, and the second camera and observing the location or the room of the student doing the examination. I think this is we suggest to do like this, but not of all our students have more gadget to do the technique. So we still allow the student to do the examination with only one camera, only from the computer. But still, so because this is very difficult to us to evaluate the other target or learning target beside the cognitive. So about the psychomotor, as a doctor, we also have the competency in a psychomotor or in a skills way. So we need to do it in the offline learning. So why we suggest to do the hybrid or offline learning immediately, because we don't want to lose like a 1 or 2 generation doctor that cannot do the examination in a proper way to the patient. I think this is our comment. Thank you.
Thank you, Prof. Ramdhani. Does anyone else from the panel would like to add about evaluating competencies in hybrid mode? Any experience that you would like to share on that? Okay. If not, the next one goes straight to Professor Sanjay Rampal. He's asking, can you describe the trust node a bit more? Was this in place before pandemic? Will it stay placed post-pandemic? And do you have a measure of impact on public in terms of trusting the node for information and influence decision regarding vaccination and treatment related to the pandemic? Professor Rampal? You're still on mute.
Thank you, Professor Yodi. Thank you, Robert, for the question. Now, the trust node is a relatively new concept. It was not there prior to the pandemic in our institution. This was actually recommended by WHO when early in the pandemic there was a problem with misinformation and disinformation. And this issue of misinformation disinformation is actually rather recent if you look at history. And there were a lot of problems with getting reliable information. And so our institution, our faculty realized this, and we had then attempted to become a trust node for Malaysians at least. And so it started off in March to May of 2020. And what we did is there was also issues with official information coming out from the government, because the pandemic management is through the National Security Council of Malaysia. And so there was a security domain over everything that was coming out, oversight. So there was also a media ban on Ministry of Health staff in providing any information to the mass media during this pandemic. So it was an organic effort. And what happened is we started, once we decided to do this, we started writing up on current topics. We disseminated information through traditional mass media, the TV. Many of our academics started getting involved and started presenting in the TV, writing articles in the papers, opinion pieces, and being interviewed in the paper, and coming out on radio interviews. In addition to that, we also amplified our messages through social networks, and especially by getting connected to social media influencers who, via Twitter or Facebook, who then picked up on whichever topic which was timely at that point of time, and they amplified our reasoning. We also had webinars in order to amplify any messages that we had at that time. Now, examples of topics that we have addressed is, if you look right from the start, it was the need for community quarantine or lockdowns. Initially, we were pro for a lockdown, but later on we moved on from the lockdown. We said that we couldn't contain the disease, so the messaging that was coming out from our center was lockdowns cannot be instituted for prolonged periods of time. And this was a problem in Malaysia, where we had a highly intensive NPIs, non-pharmaceutical interventions, public health measures, restrictions, travel restrictions in place for over 18 months. And at the end of the 18 months, we had the largest outbreak ever. So that there was issue with pandemic fatigue, and I think Ramdhani had picked up on this. So there's also issues with vaccination, from the time of when to procure the vaccine to who should get the vaccine. There's a big issue with vaccine hesitancy, and I think we have addressed vaccine hesitancy among adults. There are those anti-vaxxers, but those are actually a very minority group. They're very vocal, but they're very small in proportion. Another big issue that we have tackled is ivermectin. And I think ivermectin was a very, very big issue, because what it did was it gained traction among pockets of populations, and it became very difficult to send messages to these populations. And so those are type of issues we did. Now, with regards to impact, so initially what we monitored who caught up our information. That means which mass media picked it up, the number of posts that were being viewed. Slowly, then what has happened is members of our trust node became involved with ministerial task force. So this was independent of the pandemic management as independent task force committees, and also eventually getting involved with government, different agencies of the government that were looking into the pandemic management. And I think that that's a very brief summary of our trust node. The idea of a trust node is to become a believable source. So believable is very important. That means the community that you're aiming for must believe in you. They must perceive that you are a reliable source of information. And once we have established that, I think it became very much more easier to disseminate information that we wanted to. Thank you.
Thank you, Prof. Sanjay Rampal. I want to continue with your question to everyone into the panel, which is how do we prevent healthcare worker burnout in the post-pandemic period? Perhaps Professor Andrea Lum could address that.
Oh, thank you. Well, you know, what I'm hearing today, and I love the word trust node, because the trust node also extends to our culture of wellness and well-being. I think organizations need to provide the support from the top. The leaders need to really believe that providing well-being support and wellness support is not a luxury item, it's a necessity. And until as physicians, we believe in that as leaders, and then we provide the necessary tangible resources. Part of the frustration that we experience in Canada, and we are the first academic program to actually have a comprehensive program where every single department has their own well-being lead. So you're talking to your peer. If you are a surgeon, you've got a peer surgeon. Now, you might not wish to go to somebody that's very close, but then you have a whole host of 50 other people to choose from. And that's really key in establishing that trust. So organizations have given a lot of lip service, you know, building more resilience programs and teaching people how to relax. Those are important as well. But when you're in crisis, you do not have the time or the mental fortitude to go searching online to find those self-help resources. What you need is somebody to contact. And typically in many facilities, particularly hospitals, if you're an employer, and so in Canada, physicians are not typically employed by the hospitals. We have privileges. And so the hospitals will tend to say, we have benefits that we provide for our staff. Physicians are treated differently. We're almost like subcontractors or independent contractors. And so when you are asked to dial into a hotline and you don't really have a connection or trust, and you talk about vaccine hesitancy, why would you really trust somebody on the other side if you don't know who that person is, right? And by having that network of peers who are trained, whom you can trust, and I will tell you, it's a bit of a double-edged sword. I have to be very careful in telling you that we've had near misses. Am I able to report it and publish it in a journal? These are confidential, psychologically safe conversations. But we truly have encountered that. And I will shudder and know that if we didn't have our program, we'd probably have some worse statistics. So if you are thinking of preventing burnout, I think as every single, whether it's a peer for peers for physicians, or peers for an entire organization, you need to have that commitment by your senior leaders to invest in the resources. It takes a lot of time. It takes a lot of commitment to put in those tangible resources to help physicians themselves. And that's why we have developed our program to be able to help organizations train. And right now, we're in contractual negotiations across Canada to be able to deliver on training individuals. I'm a radiologist, so I'm trained in reporting CTs and MRIs, but I don't think you'd want me as a generic physician to come and take out your appendix. That was like 30 years ago when I was doing my internship. So we need to train people and also keep up their training and to support them. You can't prevent it otherwise, unless you tell me we've got the perfect medical system in Southeast Asia, and I don't think any country does. We continue to face those challenges, as we must, but we also need to put value in the physicians that we have today, because we're a very expensive resource. It takes so many years to train a physician. So if we're really going to go down that path, when you talked about public health, well, what about physician health? How many of you have those conversations around your table? And I truly know that we've had to leverage our back-end resources, in that if somebody calls in crisis, we know that we can directly refer them very quickly. Somebody needs a friend to talk to, an empathetic conversation, we can also provide that. So I think that would be the basis of how we would prevent burnout. Thank you.
Thank you. Thank you, Professor Lam. So I think we only have time for one more question, and this one for Professor Zhang. The question from the audience, they want to know whether there are difficulties in hybrid learning for medical students in TUSM as a specialty with the correlation of Family Medicine Center program. Professor Zhang?
I will address this question in brief, and I would say, nothing can replace the in-person teaching. That's clearly that the education-wise of the medicine is different from any of the other subject and for teaching. So I would say clearly the in-person demonstration and clearly need to be there. So what we try to do is we try to get the student to have more of the involvement faculties, because China, we do have the WeChat groups for that. Secondly, we will ask the student to discuss with each other, for the clinical aspect of the demonstration. They will get grouped together to get their kind of assignment done together. They will criticize each other, then get the faculty more involved in this process, try to enhance the quality of the online educations and for that. But China now is getting almost back to the normal. So most of those clinical, especially of those operation related or the skill learning related, are more back to the normal of the on-site education. But pandemics, unfortunately, that's the things we're facing, and we are facing the challenge of difficulties for how we do effectively for teaching international students, because those international students like from Asia area, from American area, are not able to back to China for those teaching educations. So we try to do more of that and to help those students, like MBBS class student. So it is a not easy task, and but that's just what we can do, is get more of involvement, go more of like online demonstration things. Like certainly, I think for the future, like a virtual educations also can be for that, and virtual needed to be on site. But if we can get a special small unit for the virtual education purpose, that could be helpful also for the future. We need to really think about that. If some kind of more of the one-person use of virtual devices can be helpful for clinical education. So that's my 3 points. Thank you very much.
Thank you very much, Professor Zhang. I realize that there are still some questions, but we are out of time because it's 11:50 here in Jakarta as scheduled. So I'm just going to end this session with a concluding note. So colleagues, today's dialogue clearly has been very rich and certainly give us food for thoughts to better prepare our academic health centers for the next crisis by improving our academic health centers' resiliency and enabling us to recover better. And this basically highlights the importance of having forums like this to enable us to learn from each other, and basically highlighting the need for our academic health centers to be learning centers, learning organization which continuously learn to improve the system to be more resilient. Now, on that note, I would also like to draw your attention to tomorrow's program. We have 2 panel sessions on leveraging artificial intelligence in the era of COVID-19 and the future of medical education, strategies and planning. Please refer to your emails for access to day 2 of those sessions. So with that, I would like to thank all the panelists for sharing your experience and to all of the attendees for joining the sessions. See you all tomorrow for those exciting sessions. And in the meanwhile, stay safe, stay healthy. Thank you very much, everyone.
Thank you, Dr. Yodi, and thank you to all the panelists.
Thank you. Good night. Good morning.
Good morning.
Bye.
Thank you,
Thank you.
Dr. Yodi. Thank you, everyone.
Thank you very much for the organization. Great. Yeah. Thank